Hello dear friends and colleagues, we are very happy to introduce to you OmniFlow. OmniFlow is a unique, novel, small and the best glaucoma drainage device which is a sutureless sure shot shunt to drain aqueous humor from anterior chamber to the retrobulbar space. A microvalve is fitted inside the tiny silicone tube of OmniFlow, which controls the outflow of the aqueous humor, which will maintain IOP between 10 and 10 for 24 by 7 for the lifetime of the patient. This is how OmniFlow tubes look. This is the anterior chamber end, this is the retrobulbar end, and the retrobulbar end contains the tiny valve inside the tube. Intraluminal pressure regulator is akin to a venous valve having microcilia which will control the flow matrix as well as the direction of the aqueous humor. If the IOP is high or aqueous secretion rate is increased, microcilia of the valve will open more and allow easy passage of aqueous humor. This is the comparison between low pressure and low volume versus high pressure and high volume. Reflux of fluid is well, but not absolutely resisted and restricted by this microvalve. Intralumen valve is much smaller than a rice grain and is much smaller than the Ahmed glaucoma valve. There are two models of OmniFlow, L50 for low glaucoma and H75 for high glaucoma. This is how OmniFlow looks in double sterile ETO pouch. Let us see few videos of OmniFlow. The tube is primed with 27 gauge cannula and primed with BSS, and as we can notice that the discharge of the aqueous humor is proportionate to the pressure which we create in the syringe. With low pressure there will be no drops falling, with high pressure there will be jet stream of aqueous coming out, and with medium pressure only drops will be coming out. After putting L cut in the conjunctiva and after a little blunt dissection, insert a vectis to reach the retrobulbar space, which is very easy. We can insert almost 40 mm of vectis which goes into the retrobulbar space and creates a track. A gentle bipolar cautery is done. Now we make one scleral tunnel which is made by angled MVR 20 gauge, 7 mm away from the limbus at 45-degree angle. The tunnel is now lubricated with viscomethyl. The beveled end of OmniFlow is now inserted in and passed through the scleral tunnel. Three-fourths length of the tube is pulled out. The valved end of the OmniFlow tube is inserted into the retrobulbar space. It goes quite easily as if a rope is falling into the well. The excess length of the tube is pulled back and pushed into the retrobulbar space. Now a second scleral tunnel is made which is radial or perpendicular to the limbus, about 2 to 2.5 millimeters from behind the limbus, which is then entered into the anterior chamber, bisecting the angle between the endothelium and the iris. The beveled end of the tube is now inserted into the anterior chamber via the second scleral tunnel. Only the bevel goes into the anterior chamber about a millimeter or 2, maximum 2 millimeters. Then the excess bend of the tube is pulled back and which is then pushed back into the retrobulbar space. The firm anchoring of the tube is confirmed by vigorous pull, push and sideward movements, and as we can notice here, no matter how much we nudge, the tube will not budge. Tube cannot be pulled out unless we want to pull it out. It's firmly anchored. It's not going to migrate. It's not going to move on its own. Now we put fibrin glue and the conjunctiva is reposited back. The entire surgery for this is sutureless and it takes only about 10 minutes to do the surgery. Except this special tube holding forceps, no additional surgical armamentarium or instruments is needed. Not only dedicated glaucoma surgeons, but any eye surgeon can easily perform OmniFlow surgery. OmniFlow surgery is cost effective, is quick to learn, and is as sure and as secured as phaco plus foldable IOL in the back. This is the CDCSO DCGI Indian FDA registration of OmniFlow. Very soon, OmniFlow is going to revolutionize the way we perform glaucoma surgery. Thank you very much for your kind attention.